Today let's talk about ascites. Definition: ascites is accumulation of fluid within the peritoneal cavity. Most probable cause is cirrhosis of the liver. There are few mechanisms identified. One is sodium and water retention, due to activation of renin-angiotensin-aldosterone system. Portal hypertension can also cause an increase of local hydrostatic pressure. Low serum albumin, due to liver failure, causes a fall of oncotic pressure. Clinical features include abdominal distension over days or weeks, abdominal pain, and if severe, suspect spontaneous bacterial peritonitis, and respiratory distress which can accompany tense ascites. Main investigation is a diagnostic aspiration of 10 to 20 milliliters of ascitic fluid. Then following components are checked. Cell count. Neutrophil count more than 250 cells is suggestive of bacterial peritonitis. Protein levels. Serum, ascites albumin gradient is measured. If gradient is higher than 11, a mechanical block is present such as cirrhosis. If gradient is lower than 11, an infection such as tuberculosis or malignancy can be suspected. Gram stain and culture and cytology is also done to exclude infections and malignancies. Amylase levels are useful to exclude pancreatic ascites. Other investigations include daily weight chart, serum electrolytes, serum creatinine levels and GFR. Management options include bed rest, which will improve diuresis. Sodium restriction around 40 millimoles per 24 hours. Fluid restriction is only done as sodium levels below 128. Diuretic of choice is spironolactone, 100 mg daily. Furosemide 20 mg per day can be added, but look out for electrolyte changes and hypovolemia. Managing tense ascites. Paracentesis has to be considered. Main drawback is hypovolemia and renal dysfunction. Around 5 liters can be aspirated without much trouble. If more aspiration needed, albumin infusion is often needed. Spontaneous bacterial peritonitis is a dangerous complication of ascites. If any patient with ascites starts deteriorating, spontaneous bacterial peritonitis should be suspected. Because pain and pyrexia are often absent, usually organisms such as E. coli, Klebsiella or Enterococcus can gain access to peritoneum via hematogenous spread and cause this. Diagnostic aspiration and culture and ABSD should be done. Broad-spectrum antibiotics started such as cefotaxime. Non-selective beta blockers are stopped. Mortality is increased and secondary prevention done by nitrofurantoin daily. Transplantation is considered. For resistant ascites, inserting a transjugular intrahepatic portosystemic shunt has to be considered.